I'm going to talk about emergency upper gastrointestinal bleeding. I have to put my declarations, which are usual for anyone doing a talk. And I suppose why are we doing this talk? Why I've been asked to do this talk is because we're all very aware of the consistent, repeated data of a 10% in-hospital mortality and the big burden of 85,000 patients a year coming in with GI bleeding, most of which are upper. And I suppose what we're trying to do is do our best. And actually, there's really good evidence. So doing a talk like this is actually quite good because there's been good evidence to really know what's the best thing to do. And that's both in medical treatment, the endoscopy, when and with what, and then what, and by whom, which I think is quite an important topic I'll try and get to at the end. And it's really just because we've all been in this situation where this has been presented to us, and in the middle of the night or during the day, and there's this sudden rush to try and sort out what can be a huge bleed. And we've also forgot that, and sometimes underprepared, especially to change our footwear, and that's not a red stripe, unfortunately, that's someone's very nice shoes getting bloody, with as one of our fellows unfortunately found out when there wasn't enough preparation. And you think, well, is this a new problem? Well, I said to someone last night, and for Dave, I'd put some Scottish theme on it, and Macbeth said, I am in blood stepped in so far that I should wade no more. And I think that's probably what that research fellow was thinking at the time when they were knee-deep in it. So let's go with the evidence. The scoring systems help dramatically, and I think it really helps our decision-making. It's Glasgow-Blatchford now. It's been used in all the trials. A lot of evidence is now based on it. Rockall was great, and a few of the scoring systems were very good. And there may be more developments in the future, but currently use this. It's easy to calculate. Bloods are really rapidly available now, whether it be blood gases or whatever it is in a resus situation. And it's also, of course, it ends up decision as do nothing or send the patient home, given the extremely low mortality, which is the same as almost background controls with a 0 or 1 score. And then greater than 7, we need to think about doing something. And then usually this idea of greater than 12 is really when the mortality starts going up. And really the advice that endoscopy really should be considered more urgently. And then you call the GI bleed consultant on call, who will come in, obviously, and as the hero factor, will come and sort everything out. But the question is this right, and is this practice? And this practice has been questioned. And it's really about this idea of making and getting your patient as good as possible before we think about intervening. And resuscitation is obviously something we always ask about and always think about, and it's, again, really evidence-based. The restrictive transfusion idea of not just, I was in A&E a few nights ago, and the idea is just replace blood with blood. But the idea of just filling a patient up now, especially in patients with suspected variceal bleeding, can do harm. And, the multi-center Spanish trial, wasn't it, they showed that if you over-transfuse, if you start aiming to these high levels of 90 and above, you actually do harm, and the idea of causing repeat bleeding. But that's really, mainly in the group of Child's A, B scores with liver disease. Do think about higher, especially in patients with ischemic heart disease who are not going to tolerate such low hemoglobins. And the UK trial, the Trigger trial, was actually looked at nearly 1,000 patients. It was a little bit more liberal with their levels of 80 and 100, but didn't actually find any difference, but did actually notice, obviously, there's a lot less blood given. About 15% of blood used in the UK is for GI bleeding. So to lose a bit less is not doing any harm to the health service at all. So do be restrictive with your transfusion if you can. Just while I was talking about blood, coagulation, anticoagulation, I've not mentioned that on the slide, but please don't let that stop your decision process. If you need to perform an endoscopy, do it. If they're unstable, reverse it if you can, but omit it, of course, at the time. Haltit's trial was slightly prophesoric in the fact that it was a negative study, so don't give it, the tranexamic acid. PPI has been done really well in a couple of prospective randomized trials by James Lau and the Hong Kong team. Subsequent studies have looked at the benefits of this, and it is really with regards to reduced need for endoscopic therapy and reduced hospital stay. IV PPI before a procedure, NICE originally in 2012 said, probably not. ESGE said, yeah, give it. I think if someone's nil by mouth, they won't get any PPI. If someone's coming with GI bleeding, they're going to get PPI, and it's there. You know, I say give it, so there you are. I can be told off for that one. And what about after? Well, we do DI therapy. We write them up for bags and bags of IV PPI. And I think, as initially, I think the evidence was good. Again, reducing rebleeding. You know, we don't want, it really disappoints us when we get all this equipment and then patients come back to have to be rescoped or have to go on for further therapy. But I think an IV PPI infusion after an endoscopy is definitely a good thing to start. What's really important to realize is that there has been a meta-analysis and other studies looking at changing this to oral doses of standard PPI therapy and tablets, and there is actually no difference in the outcomes. It's actually interesting because the Lao study in Hong Kong, after 72 hours of IV omeprazole, so 160 milligrams of omeprazole in 24 hours, after that finished, they then put them on 20 milligrams once daily of omeprazole. So it's a huge shift. There's not many people get discharged after an endoscopy on that dose. So think about all. So maybe don't skip the drip, but maybe swap to orals afterwards. You know, don't persist, especially in patients who have difficult IV access. You know, the drip stands are going off and so on. So do think about alternatives. A quick slide from variceal bleeding. If you suspect liver or variceal bleeding, the data regarding antibiotic prophylaxis is massive. It's really good for mortality, so please give antibiotics. And terlipressin, of course, has a significant effect. It's almost equivocal to balloon tamponade or even endoscopy in some studies. So make sure that's gone in. Even if it's just maybe the one dose, and then review the regular dose after the endoscopy, just given the side effects, heart failure, which I've seen once develop, and liver ischemia. So give those, please. So one of the talks we said about emergency, we talk about endoscopy and when we should do it. So definition has been used in studies. Emergency, less than 6 hours. Urgent, less than 12 hours. Then early, less than 24, and delayed, longer than 24. And really everything says, please do an early endoscopy. However, there's been two quite good studies. There's an original Danish study in GI Endo a few years ago, which was retrospective, looking at admissions and mortality, and especially in patients who were with higher ASA grades, actually doing early endoscopy, which is the first part, the hours along the bottom of this slide, which obviously you see it just starts falling in the first 10 hours. So they thought, actually, is there an idea that we're actually rushing in too quickly with some endoscopies before patients are fully prepped? And do you get a lower mortality by waiting a little bit? They asked for a prospective trial to really assess this. So obviously this was delivered by Hong Kong straight away, and James Lau sorted out a fantastic randomized trial of scoping people either less than 12 hours as an emergency in less than 6 hours or later, which kind of worked out as a median of about 10 and 25 hours. They had a consultation on admission by a GI specialist or fellow, so that's quite an important thing to say. So it wasn't a case of, we'll just do it whenever. They had quite intensive monitoring. It's quite good to see as well that actually there, despite all that effort and I suppose that was taken with the study, the mortality rate is still quite high. You know, the 10% that I quoted earlier is still hovering around when people say between 6 and 8.9%. But actually found no difference in mortality by doing an emergency endoscopy and an early endoscopy. They did exclude patients who were unstable, who they just could not stabilize, and they only had 10% again with variceal bleeding. So I don't think those two groups should really be represented in the rest of the study when applying whether you should scope someone or not. So in summary, from that point of view, emergency, well, it's slightly worse for the outcome for the patient. Urgent, well, that's the same as early with patient outcomes. So really, it's early, really. Less than 24 hours is when a gastroscopy should be performed, taking into account those papers' exclusions, which was unless you can't stabilize a patient, rebleeding or variceal. So we get them to endoscopy. What should we do? Well, I'll quickly go through this. Is we now know that you should just not give adrenaline on its own. You should either give something else or as dual therapy, and experience counts. Don't ever give up your gastroscopy list if you're on call for GI bleeds. The numbers speak for themselves, and the same with intervention. So let's talk about some things. We'll see if this video works. I hope it will, but if you're able to play it, it'll be great. So this is Hemospray. We talk about this is going to save the world, and it has been shown to be really effective when it comes out. So this is a classic example of where Hemospray benefit. This is a significant bleed going on in someone's esophagus in the dependent part. This patient wasn't intubated. If it was a clonic bleed, you'd roll the patient. But at this point, we can't do it because they aspirate. So actually, you need to get control very quickly of a situation to really be able to sit and think. And by applying Hemospray down to what had been a significant bleed, which was causing a risk of aspiration, an unstable patient, you can actually get real-time, very quick control of a bleeding situation, be able to take the scope out and reassess the patient for either intubation, a further attempt, or actually resuscitation, and actually have a think about things. And you can see really with the spray, you can usually get very rapid control. Obviously, the tips with Hemospray is that it's usually procedure-ending intervention just due to the large volume of CO2 that gets infused with the device. And then you have to think about what to do with the other 98% of Hemospray that comes in with the device as well, because I think you could probably do the whole GI tract, the amount you get. So that's Hemospray. So very effective first line, but if you use it, expect a rebleed or plan for a rebleed. There's other gels on the market. Purestats come in now. This just play automatically, I think this is an ESD we did the other day, and it's now really used for preventing post-ESD bleeds and intra-ESD bleeds, just because it forms as a gel that comes out and causes, and it works. In an acute setting, the evidence hasn't really been developed yet, so it's currently on hold. So at the moment, Hemospray for acute and a Purestat for prophylactics, because unfortunately, upper GI ESDs do have quite high recurrence rates. What about other things as well I'd want to talk to as well? So we go to courses and we hopefully pick up a lot of things about the clips and things. And the Overscope clip is always touted. But so it has really good randomized study looking at using Overscope clips for rebleeds, and I think that's probably one of the better times to use it. It's quite a significant device, whether it be the Overscope one or the one at the bottom called the padlock. It's slightly wider than an esophageal bander, so it is a difficult intubation. You have to go in slowly with it. You can play this video as well if you like. Thank you. And so you have to get it through the pylorus slowly. You have to go there. So this is a recurrent bleeding duodenal ulcer with a visible vessel that has already had 2 lots of endoscopic therapy attempted with it. Apologies for the bubbles, but the cap does give you great visualization. So you can see the grippers on the top and the bottom of the cap, which you've just got to be a little bit careful with it. And it works very similar to a bander. If you can use a bander, you can use one of these clips. And as you say, you position it over the thing, just like a bander. As soon as you suck it, you get a red out, usually as the vessel goes, as you can see there. And then you deploy the clip with a very similar deployment system to a variceal bander. You keep it on as long as you can and then let it go. And then you can just see the clip just buried in there to the duodenal mucosa. And as part of it's not something you usually would just pick off a shelf and use first line without even knowing what's there. It's something, as you say, you know there's an ulcer there, and you know that it's something that we want to do. What about scoping again? I think we know it. Thank you. We've got 1 minute left, haven't we? It does work. It does have an effect. Do it, maybe with a scope, but just and it does reduce rebleeding. So rescopes should be considered. Angios do work. They're very effective in a patient that's adequately worked up. I'll miss that video. And if angio fails, well, even ultrasound, you can play this video and then we'll finish. Even as an ultrasound scan, which I do a lot of, is, you have to go back. Can you please play that video again? Is that okay? is this is an endoscopic ultrasound of a failed angio attempt at a bleeding splenic artery aneurysm, which was bleeding into the stomach. Maybe it's one of your patients, actually. But so you can actually see, by positioning an ultrasound probe into someone's stomach, you can actually see this splenic artery aneurysm, which is actually right next to the stomach wall. And this was someone who spent 2 hours in an angio suite trying to access the splenic artery aneurysm. And just by actually placing a needle, a 22-gauge needle, through the gastric wall, that's 2 centimeters away, into an aneurysm, you might think, oh, that sounds a bit scary. But by putting thrombin in, you can just ablate it. It's interesting, actually, how we don't use that much thrombin in the country for our variceal bleeding injections. We seem to use glue all the time, whereas thrombin's fantastic. Thank you. So last thing to say, education, and Motifique runs a great course here. The BSG support it. Lots of people really are desperate for education with GI bleeding and hands-on experience. So please access these courses. The next one's in December in Sheffield that we're trying to run. And there is support from the BSG. So I think hopefully I'll summarize everything by saying that, Macbeth said it all. Will we be going to sleep now? As Lady Macbeth said, I don't think so. I think we'll be called a lot. We may not have to go in. So not sleeping, and I think it's more of a call, bat phone than bat signals. All right. So thank you very much for your time, and hope that was available soon if I skipped over any of those slides. Thank you.
Thank you very much, Andy. That was an excellent talk.